I was one of the few people in the room and one of the few people in the planning that didn't get to meet Dr. Cook and didn't spend time with Andy Cook, but boy, have I heard stories about his devotion to making sure we provided magnificent care for children in our communities. And that devotion carries forward. His life partner, Jackie, knows Andy would want us to make sure that we're doing all we can to support our clinicians in providing excellent care for children, and that's why we're here this morning. So I really want to thank you all for taking the time out of your day, for joining us here at Parkview. This is the perfect space for this because this is what we do here. We find ways to improve the way we provide care. So ideal spot, an ideal group, and I want to thank you all so much for coming. Very excited for us to kick off. And with that, in a moment, once she gets a glass of water, I'll kick it off to our first speaker, Dr. Amy Mayhew.
Who in the room here has been touched by suicide? Has anyone not been touched by suicide? Lucky you if you have not. I did want to speak a little bit about ways in which my life personally and professionally has been touched by suicide. So when I was a young adult, an 18-year-old friend of mine who was a year below me came out as gay, and his family didn't deal with that well and drowned himself. I had a friend who I had lost touch with from high school who was going through divorce. His father was a pharmacist, went into the pharmacy, took a lethal dose of potassium. When I was in medical school, I had a 28-year-old classmate that overdosed due to depression that none of us knew about. While I was in residency, I had a 19-year-old schizophrenic patient who hung himself. Actually, this person did not kill himself, but had a very profound impact on me. I had a 56-year-old patient at the VA who was a helicopter pilot who tried to shoot himself and failed, and so was a paraplegic in the hospital that lived at the VA. When I was when I was a young attending in Boston, I had a 35-year-old patient with PTSD, borderline personality disorder, went back to get some paperwork from her parents and hung herself in the basement. Other patients that had overdoses. Since I've come to Maine, I treated a 16-year-old at Barbara Bush, who shot herself in the head and subsequently passed away. A long-term patient of mine that I actually had from Boston that moved to Maine became psychotic and jumped off the parking garage. I had a family friend who's schizophrenia who lit himself on fire last year. And then I also had a patient that I'm going to talk a little bit about, a 16-year-old who died of exsanguination. So I just wanted to put out there that we're talking about statistics and all these things, but it's very personal for me, as I'm sure it is for most of you. And so I just kind of wanted to point that out, that it's not just about, let's talk about the facts about firearms. I think about these people most every day, if not all of them. Big picture, people over 85 have the highest suicide rates. What we're going to talk about today is the 10 to 24, but it's not nothing. And to me, actually, it's pretty impressive that this age group is not that much different in my mind from these older age groups. Rates increased between 2000 and 2018, and then decreased right before the pandemic, and then have recently increased again. I'm going to show another slide like that. This, to me, was kind of shocking, too. This is the rates in Maine compared to the national average. Rates are not the same in every group. They increased 2.6% from 2021 to 2022. But they did decrease slightly between in youth and Native American populations. This is why we talk about firearms, why it's important to ask everybody about firearms. 55% of this is I think from 2020, of deaths of suicide, are by firearms. This is just some statistics about youth and suicide, and then I'm going to talk about a particular case. So again, like I showed earlier, 10 to 24-year-olds account for 15% of suicides. It's, the rate may be lower than some others, but it is the second leading cause of death for this age group, which is why we're talking about it. Suicide attempts are more frequent with girls than boys, and youth and young adults have high rates of emergency room visits, as we all know, for suicide attempts. This is kind of amazing to me. So if you look at these rates, and anybody who spent any time in the emergency department knows this, 354 per 100,000 compared to 128 per 100,000 among adults. So that's quite a shocking statistic to me. Females, again, have rates that are more than twice that of males. And in 2021, 9% of high school students reported attempting suicide in the past year. I think that there's this kind of thought that's kind of spread among the lay people that you can prevent suicide, you can think about what happens, you can really intervene. a very large percentage of people, especially young adults, it's impulsive. So this 33% of people under the age of 17 had a crisis within the last 24 hours and killed themselves. So these attempts are rarely out of the blue. Usually there's like long-term stressors, family stressors, but there's also can be short-term stressors. And one of the most powerful risk factors are lethal methods. So in this state, in every state, we should be asking about guns, medicines, things that people can have access to, because if you can delay that time frame, and I'm sure other people are going to talk about this as well, that might be a chance for someone to have an intervention. 90% of people that have a suicide attempt that do not die, and we're talking near lethal attempts, so we're not talking 5 pills, we're talking near lethal attempts, do not commit suicide afterwards. And 85% of people under 18 that do commit suicide by firearm, it's a firearm of a family member. Again, thinking about time between deliberation and action, 24% of people have near lethal attempts. This is ages 13 to 34. Thought about it less than 5 minutes before they made an attempt. 24% 5 to 19 minutes, 23% 20 minutes to an hour. So we're talking almost 75% under an hour between thought and action. These are just some other studies looking at similar facts. So a third of people under 18 had a crisis within 24 hours before they took their lives. The proportion of having a crisis right before the action declined with age. So meaning the older you got, the more maybe there was some frontal lobe involvement. In some cases, it was not just the same day, but the moment before they made the attempt. Another study looking at self-inflicted gunshot wounds found 24% of the attempts were due to an interpersonal conflict with a family member. So thinking about all our families out there. And again, these are, so taking a step back, we know that there's not good research in the United States about guns. So these are small studies, right? So who knows if we actually did research looking at gun violence or lethality with guns, what this would look like. But most of the studies I've seen have similar numbers. So again, there's another smaller study that found 60%. It was within 24 hours, and again, it was due to interpersonal conflict. I'm going to talk about a patient of mine. I'm going to call her Eden. She was 17 when I met her. She was a junior in high school. She'd had a long history of self-injurious behaviors, but had no suicide attempts in the past. She did report wondering what's the point at times, but at that point was actively engaged in school. She had a boyfriend. Her mother was involved. Her parents had separated when she was young. I think she was like 5 at the time, and her dad did die of an overdose when she was about 11. There's a long history of neglect and abuse. He had a lot of physical abuse with her stepmother, which is one of the reasons she quit spending time with him. She did feel unloved and would talk about her relationship with her father. It caused a lot of discontent for her. And as I said, she stopped visiting him due to the physical abuse in the home. I saw her through peer eventually. She did have a history of auditory visual hallucinations, relatively mild in my mind. She heard words and sounds. Sometimes she would see these elongated cats. It would happen a couple times a week. She did have thoughts of hurting herself, but had never had any, like I said, serious suicide attempts previously. She had a history of autism that had been diagnosed as a young adolescent. She was very high functioning, and she'd had 2 past hospitalizations. So she she was referred to us by an outside psychiatrist. She began therapy and coordinated specialty care with us in November. She was referred, as I said, from different psychiatrists. She did have episodes of deep cutting. It's probably some of the deepest cutting I'd ever seen. She did have to have wound vacuum treatment at times due to the amount of cutting she did. When we asked her why she was doing that, she said she didn't feel validated when she cut less deeply. She said that the cutting, when we asked her about suicidal thoughts, she said she cut because she did not want to commit suicide by other means, and she would never tell us what those means were. She had a lot of difficulty in tolerating any kind of distress, so anytime there's any kind of emotional dysregulation, she would return to cutting. During her time with us, we did diagnose her with bipolar disorder and put her on a mood stabilizer, which she said was helpful. She was doing therapy. She's kind of funny because she would come in and she'd be like, okay, I have to get to work. Let's get to work. And she would do her therapy, and she's like, I don't really want to be here. But she actually did really participate in the therapy and had a good relationship with the therapist. So we started seeing her in November. By April, so we had changed her mood stabilizer. The first one didn't seem to be working so great, but it seemed to be doing better with her moods. But she continued to have these explosive episodes that we started to think was more related to probably a personality disorder and less related to a mood disorder. She would have these episodes with her mother and her boyfriend. They would call crisis. They'd come to the house and then settle things down. with this diagnosis, we kind of shifted some of the therapy we're doing, but, felt like we were making progress with her. She was having issues, but, felt like things were going in a good direction. Her mom, around this time, came into a visit with me. The patient was there with her boyfriend who was visiting from Boston, and she refused. She came in for a minute. She was very irritable. She's like, I want to talk to you. So I said, okay, let me just talk to your mom. Her mom said, I just really don't know what to do. I feel very frustrated. I feel like we're doing everything we can. We reassured her that we were going to be there with her, kind of try to help her through things. Shortly after this visit, she stopped going to school, but she, was still working in therapy, trying to identify why she's having these emotional outbursts. So really, again, feeling like we were making some progress. She got a job. She was thinking, maybe I'll just get my high set. I don't know that I want to do school right now. And she refused to talk about these outbursts in therapy at this point in time. I saw her again in May. At that time, she said she was sleeping poorly and she was having a lot of thoughts in her head. She was hypersexual. She was hallucinating. We decided to increase her mood stabilizer. She saw her therapist again in June. She said at that time, actually, I feel like my mood is pretty stable. She also said that she'd quit her job after an argument at work, and then she broke up with her boyfriend. She was really thinking about the things that were going through her head. She talked about the fact that she often acted on her emotions and she needed to kind of be able to separate her emotions from her actions. 2 weeks after this, she refused to get on an appointment with her therapist. The therapist did talk to the mom at the time, and she discussed an episode that had happened that she'd been disrespectful, but she did say, I think that she's doing okay. She's talking about going to work later this week, and then she missed her appointment the following week. So the therapist called the mom to see what had happened, and the mom said, I thought that the police would have told you, but she committed suicide the day of her appointment. What happened is there was a family friend that came to the house. The patient had reached out to the friend's daughter and sent a concerning text message. So he came over to the house. The mother, the patient, and the family friend all sat down and discussed what had happened. She said, I'm not feeling suicidal. It was just a momentary thing. It was 3 a.m. I feel a lot better. She went for a walk. She came back in and she apologized to her mom for what had happened. Mom thought things were okay. They did not contact us. They didn't call crisis. I think mom at this point had felt like she'd been through this so many times before. She felt like the patient was in a good place. And mom went to the grocery store, and then she went into the bathroom and slit her throat, and her brother found her. I'm not telling this because I want to highlight the times that we don't succeed, but just wanted to say that is part of what we do. And we thought we talked with the mom. All of us met as a team. We met with the family. We felt like she was making good progress. We felt that she's continued to have difficulty managing her emotions, but she really had come a long way from where she was previously. We talked about the fact that she had a lot of interpersonal conflict, but that's common with borderline personality disorder, and that she really was trying hard. And we don't really know what the trigger was at that moment in time. All we know is that there was a trigger, and it ended her life. One of the things we talked about as a team is, did mom have some crisis fatigue? I think that after you've been through this so many times, you think, do I really need to call crisis right now? She says she's better. You just don't ever know, I think. So this has been a really challenging case for us and our team. So wanted to bring it up because I feel like it should have some purpose. So thinking about adolescence and the task of adolescence, your task is to individuate. Hi, Casey. You want to individuate from your family and form relationships with your peers. It's often a time when you're hypersensitive, whether or not you have borderline personality disorder. You're hypersensitive to slights, and you need a solid base on which to navigate. Things happen, your boyfriend breaks up with you, somebody makes fun of you. My daughter is 17. She came home the other day and was upset because she didn't get chosen for the volleyball captain, and her 3 friends did. We sat and worked through it. A week later, they could be friends again. But these things are they feel so overwhelming at this age, and you just don't know what to do with the emotions. So these interpersonal conflicts and these triggers can make you feel isolated and can give you this sense of desperation. If you're an adolescent without good supports, can feel all-consuming. And the ability to connect with others, with your family, with your friends can protect you against this moment of desperation, as we talked about earlier, which can lead to suicide. That 5 minutes, hour from when you have this horrible thing happen to when you act on them. And those that have difficulty reaching out for whatever reason, they have a mental health problem, they have family dysfunction, they live in a rural part of Maine and they don't have connection with a lot of people, all kinds of reasons that we see every day, may impulsively act out, and it may be lethal. That's why we're all here. So what can you do in primary care to fix this problem? We had a really fabulous talk. Any of you who went, Doug, I know you were there from the Glickman. We had a really fabulous child psychiatrist from McLean talk, and I actually borrowed some of her thoughts because it really congealed to me, maybe because I was thinking about this case. Some of the things that we can do is just any kind of provider with contact with someone. Some of the stuff is talking about borderline personality disorder, which relates to my patient, but just thinking again, adolescents are kind of at that stage where they have a lot of similar traits and emotions that are all over the place. There are some very specific therapeutic factors that all of you as primary care providers can give. Being reliable, listening, showing concern for people, improving the attachment and trust. If most of you know families really well and you can identify who out there is going to be available to these kids, helping them make those connections. That's what's going to help them in that moment when they're feeling desperate, is that they feel like they can reach out to someone, helping them build that. Being available to advise and assist in situational crises. Maybe you're not going to be the one because you can't be on call all the time, helping the family understand who can they reach out to or who can the patient reach out to, giving them the crisis pyramid that I think most of you have seen. Just being able to say, oh, look, there it is, we're all going to get one. Being able to give those to people so that they know there's someone you can reach out to if I'm not available. Helping parents be available. Helping them understand that they are the ones who are around and that they can be available to their teens. If they're not in a situation where their parents are that available, and you know who those families are, helping the teens think about who else is in your life that's a natural support that you can reach out and helping them build those connections with people. Helping kids establish goals. Those are the things that might help in that moment when they're thinking about doing something desperate. Do you have a life that's worth living? Do you want to have a life that's worth living? We spend a lot of time in our clinic and our coordinator specialty clinic, what is it you want to do? How are you going to go on with your life? Okay, so that when they have that moment of desperation, they can think about, okay, but I have to do this thing for tomorrow. Just sometimes that slight movement towards, I have a goal, I have a future, will help them kind of through the crisis. Encouraging them to have friendships and partnerships, making both short-term and long-term goals. Being flexible, so help, and this is something that you can, and I know that you're not therapists, that's not how you went into this world, but you are. by default, you're all advising people and you're all helping them manage their lives. So helping parents be flexible in setting goals. So their teen comes in, they're in a crisis, the parents are mad because they don't want to continue with their college career at Bowdoin. Okay, let's take a break. Let's figure out something, don't come down, there can be changes in your life, making sure you're helping families understand that they can pick a different path. School over dating, making sure that again, keeping on goals because, thinking about the fact that how intense those emotions are at that life stage and, that whatever relationship drama you're in right now is not the only thing, getting kids to go to school and not be so focused in on what's going on that they can kind of weather the crisis. Over-reliance on romantic relationships can lead to this internal volatility that can continue to make things feel worse. And whatever's happening, they go to the hospital, they end up in the emergency department, returning to normal functioning as soon as possible. I saw a kid, I think 2 weeks ago, I was working in the emergency department, 13, was suicidal, came up with a crisis plan, spent overnight with her mother. Next morning, I saw them. They felt like things were okay. She thought that the moment had passed. She couldn't really figure out what it was that had happened, but she had a therapy appointment the following day, and she was supposed to go to her soccer tournament. Her mom's like, I don't think I should send her to her soccer tournament. I'm like, actually, I think you need to send her to her soccer tournament. It's only 7:30 right now. By 9 o'clock, you can be there. Just get her back into her normal functioning. Oh, this is kind of blurry, so I might have to read through it. So, thinking about this is again talking about borderline personality disorder kind of as an extreme example, but thinking about kind of where people are on their continuum. So if they're connected, they're going to have this rejections. They're not going to be as rejection sensitive to what's going on. If they're feeling threatened, they're going to be thinking about their own internal state and have problems with connecting to others and be devalued. The next stage down would be being alone, dissociating, being paranoid, not being able to relate to others. And then that at the bottom leads to despair. So again, trying to get people back to this connected relationships with others to protect against suicidal behavior. Here's some top 10 tips I want to give you guys. Again, this is from the psychiatrist that gave this talk at the Glickman, so I want to give her credit, but I just thought she did a really great job. First thing you can do, express concern. Don't ignore it, don't negotiate it, be present. These feelings are really terrible. I understand you're having a really hard time. Assess the risk, differentiate whether you're talking about non-lethal issues from a true suicidal ideation. I understand that I'm asking you to do a lot. If you don't know, send them to the ED. But just helping someone sit with someone to try to help figure these things out. Develop a safety plan. Ask what they think would help. You want to give people agency, so especially teenagers. So you want them to be able to think, okay, if I'm in this bad moment, I mean, part of the research about safety plans is about agency. What can I do to help myself when I'm having a hard time? If people do need to be hospitalized, they need to be hospitalized. You don't want to avoid it because it's going to teach them bad behaviors, which is a lot of what I hear in the emergency department. Safety first, always. So if you have any questions at all, you should always think about safety first. Afterwards, trying to clarify what the precipitants are. In the case I talked about, we don't know what the precipitant was, other than the fact that they had poor distress tolerance and something happened. Some mental state happened that brought her there. But you can assume that there's going to be some kind of interpersonal stressors going on that are going to cause disconnection. Maybe there's a lost support of some kind. But trying to figure out with them later, it's like, okay, next time this happens, how do we avoid this happening again? Be clear about your limits. Don't be the one to answer the phone at 3 in the morning. Make sure that you help others understand, this is what I can do, this is what you can do to help yourself, and help them understand, where's their community. I think a lot of people get burned out, especially in mental health, by trying to be everything to everyone, and you just can't do that. So I put vis-a-vis therapy, explore the meaning. I mean, you're not really doing therapy, but you kind of are, even though you're not maybe trained as a therapist. At least have a conversation of trying to understand the meaning of what's going on. Make sure you discuss it with colleagues. Don't worry by yourself. Call us, talk to your integrated therapist, talk to other primary care doctors. Call Greg. Not at 3 in the morning. And make sure you involve the family in thinking about safety issues. Safety planning, what skills they can help the kid with, and then, as other people are going to talk about, reducing access to lethal means. So as I was talking about, making sure that the adolescent is involved in thinking about the safety planning, giving them responsibility and giving them negotiating power will help them think of other ways to communicate without being self-destructive. So that's kind of like the underlying principle of this, is you're teaching them other ways to talk about things. 14-year-olds may talk about, I have to die, I want to die. By the time you're 16, 17, 18, I'm really upset right now, I need to talk this through. So this is what you're kind of helping guide them along this pathway. Making sure that you give them time to listen, you teach families to give them time to listen, give them a place to have a sounding board. Understand that teenagers do not often understand what's going on inside when they do things. And so they're not being difficult always, they truly don't know what's going on sometimes. Sometimes they can tell you, sometimes they can't. But you're there to teach them, their families are there to teach them how to communicate and think about what's happening internally. Ways to help families be involved. Remembering the family conflict is a prime risk factor, and it is a prominent feature in adolescence. I mean, I can't tell you how many arguments I've had with my 16 and 17-year-old over the past week. Sometimes I wonder if they even want to talk to me next year. I'm not sure what's going to happen, but I just hope they'll come back. And I think our relationships is pretty good. Your response as a parent can either exacerbate or alleviate the problems that are happening. And so helping parents learn how to tone down their emotionality if they're having an argument, how to step away when things are happening, can really help normalize behavior for teens. You need to normalize challenges for parents. Parents will be like, oh my God, my teenager is the worst one I've ever had, especially if they don't have contact with a lot of adolescents. All adolescents are challenging. Just helping normalize that for them so they can weather these emotional storms. Don't take it personally, just let them talk it out. They'll be back tomorrow to talk to you again. They'll need a ride to the mall. Helping the parents manage crises and responding appropriately can help them pass. If you can't handle it, role model for your teen. I need to take a break right now, and I need to walk away, and then I'm going to come back. Teaching parents to pay attention to self-injurious behavior is a communication of distress. That's not nothing. You don't ignore it. You don't say that it's a suicide attempt, but you have to realize that that's a way that they're communicating because they don't know another way to communicate or how to manage their emotions. Very importantly, family member psychopathology is going to affect how stable the home is. So making sure that if you can, getting the family members to get involved in treatment so that they can in turn be a support for their teenagers. Reducing access to lethal means, again, we'll talk about it again, but locking medications in cabinets, keeping small quantities. I'll tell you in my own house, neither of my kids have had any mental health problems so far that I know of, but all of my medications are on like a top shelf hidden behind the towels, just because. I just don't want them to be available. And all we have is like a tiny bottle of Advil and some Benadryl in our house. If you do have firearms, making sure they're locked and separate from ammunition. And then if there are substances in the house, if the adults use substances, making sure that they're limited available and they're secured so that the teens can't get into them. I'm pausing because we had a kid recently who has a lot of self-injurious behavior, has had multiple suicide attempts, and she told us that she was getting into her mother's liquor cabinet and drinking every evening. And so that was kind of a challenging situation because we didn't really know how to approach it without like breaking confidentiality and telling the mother. So luckily, the teen told us that she wanted to get on naloxone. This is a very smart teenager, she's only 14, to help with her cravings. It's like, okay. So I went to mom and I said, well, your daughter says that she's having some self-injurious behavior, which is true. She wants to get on naloxone. And the mom obviously had her, spidey sense up, and she said, I found a small, like a mini bottle in somebody's clothing the other day. I'm like, oh, really? Do you have other liquor in your house? Maybe you could lock that up, or maybe you should get it out of the house. So, parents often will know things that are happening. But anyway, it brought us as a team's attention that this is a conversation we need to have with every parent at the very beginning. Like, not wait for an opportunity that we have to like backtrack and try to figure out a way to have the conversation. So now in our intakes, we are talking about these things with all of our families. So takeaways, let the adolescent know they're not alone in what's going on. Understand that they don't often know how to manage their tumultuous internal state and that they need help from us as adults to do so. Encouraging their peers if they're telling their peers, which they often do, to reach out to adults to get some support. Lend hope that things can get better. I had a 18-year-old recently who had a new diagnosis of schizophrenia, who has an uncle with schizophrenia, lived on the streets, very rapid course, no suicide attempts, was quite psychotic by the time I saw him. And we tried 3 different medications. By the 3rd medication, he came to us and was very, very distressed about what was going on. And we asked him, are you having thoughts of suicide? And it turns out he had written a note. He had a noose in the closet. He was just waiting for the right moment in which to do it. And we spent a lot of that session discussing why we could be hopeful about his situation. And we ended up actually sending him to the emergency department. He was just there, I think, for a night and ended up going home. But he and his dad identified that conversation as being some of what helped him feel like he could go on. We talked about other patients we'd seen that had done better, and actually now he's doing quite well on medications and is going to go back to college next year. But again, thinking about these desperate moments that people have and making sure that you're available and asking the questions at that time. I always encourage people, if you have a doubt, ask the question. If you just have an inkling that something is not right, just ask. There's no harm in asking. Helping teenagers to create that wise mind. I obviously am really influenced by DBT because I just love the idea of wise mind. But that's what you're trying to integrate, thoughts and emotions. How do they fit together? How do you know what's driving what, and how do you address the right problem? Being a trustworthy role model. All of you can do that in your roles in primary care. That you can help people problem solve. Showing people that you make mistakes. Repairing those mistakes, that's really important for teenagers because they're going to think, oh my God, I made this horrible mistake, my life is over. Again, I had another 18-year-old recently who just went to college, had a DUI from cannabis, crashed his car, sobered up. Whoops, oh my God, what did I do? Came to me and was like, my life is over. I'm like, in my mind, I'm like, your 18-year life's not over. Was charged as a 17-year-old, so is looking at a felony, but, will probably be erased eventually. And just being like, I've made mistakes in my life. One of our team members talked about the fact that they'd had a DUI and that they had gone to Al-Anon and that they'd had issues and that they had a successful career. You don't need to disclose your entire life, but it is sometimes helpful to give small examples of like how you've made mistakes and moved on. Like I've done things, or repairs in relationships. I can do that and move on. It's really important to teach teens because all that black and white thinking, thank you, at that age is hard to get through unless you can provide those examples. Again, helping to make a life that's worth living and increasing that self-sustaining social capital. So helping them build their relationships, making sure they have things in their life that are going to help them have a way to weather the crisis. And then taking away access to means in these highly impulsive moments. Oops, I think that's it. Thank you.
hard to follow Amy Mayhew. Good morning. So Dr. Mayhew really did a wonderful job framing up why this is so important. Now, how do you do it? How do you do it in the middle of a busy practice? How do you do it in the middle of productivity-driven 15, 20-minute increments? How do you do it when the system does not make it easy? And there's a structure that was developed, or that was recognized first and then encouraged around the country. They called it Zero Suicide, the Zero Suicide Initiative. And when I say that to a group of clinicians, I often see the shadows drop over their eyes, say, oh my God, does that mean if we ever experience a loss by suicide, we have failed? And you're always going to feel that as a failure. But in Maine, we shifted the concept from zero suicide to suicide safer care, because it's kinder to everyone, but still with the exact same intentions. And the suicide safer care came out of an event, a 10-year increment, a study done by a large managed care company. And it's the idea, it's a foundational belief and aspiration that for individuals who are under a system of care, suicide should be preventable. We've all established that for most people, that suicidal crisis is short-term, it's transient, and it's something we can intervene with, it's treatable. So the whole idea is you can't do it as a clinician. It starts out with leadership. And a commitment from leadership, including time, structure, funding, training, and it's a commitment not only to clients and patients, but to staff. Staff who work to assess and support and treat people who are struggling. And the whole idea is it's based on the idea that in most systems, it's so easy for someone who's struggling to fall through the cracks, and I'll talk about that more in a minute. So this is something that clinicians alone cannot fix. No matter how hard we work, how hard we try, that it requires everybody. That in a system of care, everyone has the idea and built into their role that suicide prevention is part of the work I do within that role. So you all see suicidal individuals. You may not know that the individual is considering suicide when they walk into your practice or your office. In fact, fairly frequently, those individuals are going to come in for some somatic complaint. Difficulty sleeping, headaches. I mean, the famous thing in school nursing is that the child comes in with a vague stomachache. So how do you figure out the possibility that you need to assess? What do you do for screening? And across primary care over the past 15 years, there's been a real effort to kind of normalize the use of the PHQ. PHQ-2 leading to a PHQ-9, or the GAD-2 leading to a GAD-7, to do some screening to understand what someone may not be talking about. And then if it screens the possibility or their likelihood that there may be some suicidality, what tools, what processes do you use to assess? How do you get an idea of what the picture of risk is? And then for anyone who's assessed somewhere in the neighborhood of risk, what do you do? How do you work with them? And I'm so glad that Dr. Mayhew talked about the collaborative approach, working with someone. It's totally engaging them. So how do you engage that individual in a safety plan, which is very different than that acute safety plan that helps them to get through the weekend with supervision, with conversations, with resources to reach out to, but a longer term. And does that safety plan always include a conversation about lethal means, the access to it, and a plan to support the restriction, which Sheila will talk about in a second. And then finally, the next step, which has been some of the hardest to connect with until recently in Maine, how do you directly treat the drivers of suicidality? More than just a refer for medication. And there's some good evidence-based models for that. Trauma-based or suicide-informed cognitive behavioral therapy, the dialectical behavioral therapy approach from Marsha Linehan and her group, the collaborative approach to the management of suicidality, David Jobs, the CAMS model, which the state is continuing to bring training to support that. In fact, we're going to be administering some of that this coming year. And then finally, and absolutely never forgotten, how do you make sure for someone who has been recognized as at risk that you follow up, that you make sure that you are checking back in with them? And we're going to talk about some of these elements as I move forward. Because if you do these well, you save lives. You save lives. And the poster child for this is a large managed care company in the Midwest. Henry Ford, they're as a system, and they cover parts of 3 states, have got everything from outpatient practices and case management to inpatient hospital units. And they cover between 250 and 300,000 members at that time. And they got an excellence grant to really look at how they managed depression. Identification, treatment, opening doors, and it was a leadership driven. They got together and said, we want to do this. And along the way, they absolutely said, well, we're going to need to include how we manage and address the risk of suicide. So they identified systematically and assessed the risk of suicide. They opened multiple pathways. And that's what the challenge has been, certainly over the past 3 years. How do you get someone into the level of care they need? They did training for their workforce after identifying instruments they would use. And they used those instruments in evidence care pathway to assess and manage risk. And then finally, they ensured that there was continuity, follow-up with someone who's seen at risk. And what they saw, within 18 months of starting that program, their suicide rates among those 250, 300,000 members dropped 80%, 80. And they stayed in place through the rest of the 10 years, and they stayed in place beyond that, but that was a study. A little bit ups and downs, but an 80% reduction in suicides across their members. You can imagine that got people's attention. And rural states like Maine and everywhere else in the country, how do we integrate that into our environment? How do we do that here? And the suicide prevention team under Sheila Nelson has really been working to do that in a number of settings. So what does that mean on a practice level? Whether you're part of an integrated system or not, that you develop processes and protocols, understandings that survive beyond the individual clinician, that guide identification of risk, guide assessment and management. You develop protocols. And those include, what do we do to screen? What do we do to screen to identify the possibility of risk? And then how do we assess that risk? What's done in-house? What do we refer out to the crisis team or the emergency department? What instruments we're using? Are those embedded in our EMR? And how do we, for those who are assessed at risk, how do we make sure they receive the treatment they need? And we had a conversation at our table just how challenging that is right now. No surprise to me. And that how do you integrate that practice of collaborative safety planning as a practice norm? Who does it? My experience in developing those with an individual, it takes a good 25 to 30 minutes, and then following up the next time to check in and tweak it. Who's got the time? And then absolutely, how do you do proactive follow-up? So those are the elements again. We keep banging that drum to bring attention to the whole systemic nature. And how do you respond when the possibility of suicidal behavior comes in? And what I often find, no matter what level of group I'm talking to, you first need to factor in how do you overcome that knee-jerk, oh crap, when suicidality enters the room, and how do you frame yourself in a way that's helpful? So you bring in that attitude, how can I help? Where does it hurt? How can we be of assistance? And as Amy said many, many times, part of that is listening and not assuming you know. Work actively and proactively to keep someone safe, connect them with help, do the collateral contact as well within a family, and then follow up. So what you avoid? Manage your gut. Avoid overreacting with your own anxiety, your own fear, your own anger if it comes up. Don't respond in any way that's patting someone on the back, that's patronizing. And absolutely with an adolescent, with a youth, never promise, or with an adult, never promise to keep a secret where safety is concerned. But have the conversation. How do we connect you? If I need to talk to your family, how do we do that in a way that involves you? Do you want to be there? Do you want me to talk to you about what I'm going to share? Do you want to be in the next room sitting with someone else while I have that conversation? So I always think about, as I approach this in my work, what challenges do I face and how can we address those? So we've been working since 2014 using the Columbia Suicide Severity Rating Scale. And what I find now is being used in many schools. It's being used in most healthcare systems. Some law enforcement teams use the screen. And it's been incredibly rigorously studied across a number of populations, a number of settings. It's available in dozens of languages around the world. And it's so much more than that. Are you suicidal? Are you thinking about ending your life? Yes or no? It allows a quick, relatively quick, nuanced estimation of risk. Now, is it the only tool to use? No. In fact, I was working with some folks around autism and they said, well, you know, we'd like to use the ASQ, which comes out of the National Institute of Mental Health, which is a good, simple screen as well, and seems to be a little bit more validated for folks on the autism scale. But we really do support the various versions of the Columbia. And it's very clear. It's got a couple questions about ideation, a clear questions about planning, a couple questions about, one about simple intent, one about intent with planning, and then questions about history. They give you language to use. Tweak it, making sure you have the intent of the question very clear before you ask it. Because I do find some of the language to be cumbersome. And the other thing which I always loved about this model, when we did the initial training back so many years ago, 9 years ago, don't ask about right here, right now, even though if you're trying to place someone, they're going to say, are they suicidal right now? But you're going to ask it in a broader time frame. Over the past week, over the past 30 days is pretty validated. So you're going to ask about suicidality, rumination about death, and then about suicidal intention. And if the answer is no to those two, you go right to history. But if the answer is yes, or you're not sure, then you're going to move on to the middles. You're going to ask about what someone might think about how you're going to end your life. And if 18.5% of our high school students in 2021 said, yes, I seriously considered suicide, 24% of girls, 13% of boys, higher in those who were non-cisgendered, and about 13% talked about planning. And then you move on to the intention, you get an estimation of risk that helps inform. But you also always talk about history. Always talk about history. Have you ever done anything, started to do anything to end your life? If the answer is yes, was it within the past 3 months? And it's always valuable to ask also, and then what happened? You may be the first person someone's acknowledged it to. So Sheila's going to move on to safety planning, but I want to encourage, absolutely, how do you have a flag in your system, in your EMR, that says this person needs a follow-up? And if they no-show that appointment, we need to actively reach out and say, hey, I'm sorry, we missed you today. What happened? How can we make sure that we can get you in the next day or two? So you're following up. And if you can't do that, who does it? How do you train your care managers? And finally, the same note that Amy ended on. Most suicides are preventable. How do you impart that sense of hope? How do you reinforce what help looks like on all the levels? And how do you make sure within your system of care you have the training on board for all your staff so that the person that answers the phone, the person doing the care coordination, the attendant who's taking the temperatures and asking the questions, as well as the clinicians have the training in place. Reach out to us. We do that on a practice level. We do that on a larger level. And so I'm going to end there, and I think we're going to be turning it over to Sheila. Thank you very much.
All right. Hey, everybody. I'm Sheila Nelson. I work for the Maine Center for Disease Control and Prevention. And if this is starting to feel like a little bit of a broken record when you hear us talking about lethal means safety and safety planning, there is a reason for that. That is because very often when you've done that screening that Greg mentioned, you know that someone that you're caring for, a young person that you're caring for, is struggling with a mental health crisis or struggling with suicidality, it feels very overwhelming, right? Like there's a lot of moving pieces, there's a lot going on contributing to that situation. And we all get into this work because we want to fix things. That's, we're professional fixers of things. And it can feel really hard to figure out where to start to fix things. So I want to encourage you all to start here, right? You've done your screening, starting here to talk about lethal means safety. And that is because this is one of the most impactful short-term interventions that you and families of young people can do in order to keep that kiddo safe and alive until they can get the kind of long-term care, help, support that they need that's going to move them into recovery. We want them here with us to get to a place where they're feeling better. They can't do that, right, if they're in an environment where they might have easy access to something that they could use to end their life. So I like to talk about these conversations as simple but not easy, right? We're not necessarily talking about a super long, complicated intervention or a long list of things that you have to check off with people. But they are hard conversations, right? There's a couple third rails floating around in that conversation, the big one being guns, quite honestly. And it's hard to talk about guns in our culture. Take the deep breath, right? I always have to take a deep breath about it, right? Because I have my own feels, right? Like we all have our own opinions, we all have our own histories. That's not really, though, what this conversation is about. This conversation is about starting with that young person and their caregivers from a common purpose. And almost always that common purpose is some version of, you love your child, I care about them as well, I want to keep them safe, I know you do too. Can we talk about some options for making sure that they're going to be okay in these next couple days, weeks, right, while we work through this care plan together? So it's pretty rare that you're not going to have a family that is on board with the idea of protecting their child or helping to keep them safe, at least in the short term, right? Details, sometimes a little bit harder, right? But we can at least start from that place where we're joining with that family or those caregivers straight up. This is not, your goal is not to get a family to do the thing that you think they should do. We will secretly want them to do the thing that we think we should do. Let's be perfectly honest. We will all want them to do that thing, right? Our job, though, is to get them to do the thing that they are willing and able to do. So I think about that as then again, just like, that lets you take a little bit of a breath, right? It's not your job to convince them. It's your job to figure out the thing that works for them that's going to reduce the risk for that kiddo as much as possible. Something is always better than nothing, right? So even if we're pretty far down the list of things that you were like, you started with the thing you really want and they can't get there and they can't get there and they can't get there, something's always going to be better than nothing. And that even the best laid plans, right? Like being able to normalize for them that like you're sitting in this moment, you maybe are like willing and able and up for signing on to do anything that you are asked of because you're a family member who's really worried about this kid, and then you get home and stuff is messy. So you're gonna wanna get some of that planning in advance. So what are we even talking about? Generally, we're talking about three things, and I add a special category here for young people particularly. So we are talking about firearms. Dr. Mayhew mentioned the overwhelming majority of individuals in Maine who die by suicide using a firearm. And very often people think that that's less true for young people because young people may or may not be owning their own firearms. It is in fact more true. So more young people die using a firearm than adults. And as mentioned, very often, especially in the case of adolescents under the age of 18, that firearm belongs to a family member. It might be theirs, right? A lot of people get a 22 when they turn 13 in my line of work, in my world where I grew up. But very often that firearm belongs to their family members. Medications, right? Both prescription medications and over-the-counter medications as well. Show of hands, how many folks who have worked with young people who report a past suicide attempt or have heard about it in their friend group using Advil, Tylenol, right? Any ibuprofen, yes, right? And those can be dangerous medications. I mean, we really want to acknowledge, right, that although they are sold over the counter, right, if you take enough of them, you can cause some pretty severe health problems. And so we need to be talking about both prescriptions, over-the-counter medications, and potentially illicit substances as well. The one that I add for young people particularly is around supervision. And this is a hard one, right, because it is there is a limit to what we can remove from a child's environment to protect them, right? Like, so we can take out the firearms, we can take out the medications, right? But we have a certain proportion, relatively high proportion of young people who die by suicide using hanging or suffocation, right? It's pretty hard to take out any environmental thing that could lead to a young person dying that way. And so we talk a little bit about having eyes on that kid during the most acute period of their crisis. It is hard to do that. I want to be really clear, right? Like, first of all, adults have jobs, they have lives, they have other responsibilities. Second of all, as we will talk about, there is no faster way to piss off an adolescent than to invade their privacy 24 hours a day. So, might need to do it, it's gonna suck for everyone involved. But I like to talk about it because it is something that makes a difference for young people. So, what do those strategies actually look like? They sort of fall into three big buckets. The first, and what we would sort of call the safest option, and I wouldn't necessarily use that exact language with a family, but it's true, right? The more that we can get out of that child's environment, the safer that child is going to be. So if they have a firearm in the house, asking somebody who is allowed to have that firearm, right? So that could be a family member who's allowed to have firearms. It can sometimes be gun ranges will sometimes store. Sometimes police departments will. The problem is it's a little, inconsistent across the state. Get the guns out of the house. All of the guns, too. I want to say that's the other thing that sometimes comes up in these conversations where you'll say, do you have any guns in your home? And they will say no, because very often, at least where I grew up, right, a gun is a handgun. A rifle is a tool, like a shovel, right? Because, I grew up in a hunting culture, not Maine, right? Everybody has a shotgun, right? Or a rifle that they only take out for hunting season, but it's in the house, and they may not even think about it. So sometimes I'll say, do you have any guns? They say no, and I was like, so I just want to be clear, so you don't have any rifles, shotguns, handguns, and then they'll be like, oh, well, I have my, my grandfather's old .22 up in the attic, but, and that's a gun, right? That's a thing that a young person may know that is there and have access to. So if we can, get it out of the house. Get it out of the house, what I usually say then is, can somebody hang on to these for you until your child's feeling better? Because sometimes that adding that little bit at the end makes it sound a little bit less like I am there to take away your firearm, right? Which is very often the knee-jerk reaction, right? This is a temporary condition while your child's feeling better. If folks aren't willing to do that, and some folks aren't, I want to be really clear, some folks aren't, and that's okay, right? Anything we can do to further restrict access to those potentially, dangerous things is better, right? So we put the gun in a gun safe, right? That we have changed the combination to, or that we keep the keys on all at all times, right? We use a trigger lock or some other kind of locking mechanism on that. We keep the keys with us, right? Or we give the keys to somebody that we know is going to be able to keep them safe. We put medications in lock boxes, right? Our program does provide lock boxes. Although we've gone through several iterations of lock boxes because we've had young people very kindly reminding us that they can open them with paper clips. So almost nothing is actually adolescent proof, we've discovered, but we've gotten better. Putting medications, again, and people may have medications that they have to keep in the house, right? So how do we store those safely as well? that child may be on a lot of medication, right? Could we put those in little pill boxes? We lock the actual like medication vials up somewhere else. And then again, right? Not everybody owns a gun safe. Not everybody is willing to put, you know, a trigger lock on their firearm. Can we do anything at all, right, to increase time and space between that young person and their potential suicidal action and the means to end their life? So as Dr. Mayhew mentioned, one of the things we know is that the window between a young person considering suicide, deciding to take action on that suicidal impulse, and actually taking action is very short often. And it almost never happens Wednesday at 3:30 in the afternoon when you're all like conveniently in your offices. It happens at 2:30 in the morning on a Saturday. We're not going to be there. So the more time and space we have, the likelier either it is that that young person chooses to take a different action or that someone is there and able to intervene with them to keep them safe. So that means unload the gun. Can you just store your firearms unloaded for right now? Can you put the ammunition somewhere safe? Lock it in your trunk? Like anywhere that you can think of to keep those two things apart. An unloaded gun is safer than a loaded gun, right? Anything that they're willing to do, right, to make sure that that firearm is less able to just be picked up and used immediately. This is, you know, again, if you keep medication in the house, like New Englanders, y'all are a thrifty bunch. You buy the 500 count bottle of Advil from, you know, wherever. Just take most of it to work and put it in your desk, right? Keep a little bit at home. You don't have to keep all of it at home. And this is, again, that eyes-on thing, right? Where can you enlist other adults in that child's life, right? To make sure that in this very critical moment, someone is keeping eyes on them and keeping them safe. All right. So, by the way, remove, restrict, reduce is not language I would use with a family, right? Because as soon as I start talking about removing your firearms and restricting access, right? I have just, again, I've like stepped a little bit on the third rail, and that might cause someone to get a little anxious. So there are lots of ways we can start that conversation. Again, I like to start it from this place of saying, hey, we both want the same thing, which is we want your child to be safe. How can we do that together? Can I talk about some strategies and we'll make a plan together? So, right, this is the short term, right? This is the first aid of safety planning, right? Like it's getting everything out that can cause immediate risk to life for that child in this short term, right? Keeping them as safe as we can. And then can we also come up with a way for that young person, the family, hopefully together, right? This is the collaborative part of the collaborative safety planning. We kind of all need to know what's going on here. This is a little bit longer term. So how do I keep my environment safe? And then how do I sort of have a roadmap for coping, like collectively coping, when I know stuff is starting to get a little intense, right? How do I know I'm starting to feel things coming on that might not be great for me? What can I do internally, right? What can I do, you know, around in my environment, right, to help me feel better? Who can I talk to that's like a friend or a coach or a family member that I trust? Do I have some professionals, right? If I can't get to those people because it's 2:30 in the morning on a Saturday, right? Here are some numbers I can call. Here's my safety plan. Here's some of the things that I care about and that I want to stick around for. I think we already sort of talked a little bit about this, but I always want to remind adults that young people have slightly different brains than adults. Their feelings are valid, right? Like, we've broken up with 600 people, not really, literally, that sounded really dramatic. We've broken up with enough people in our lives probably by the time we get to our age that we know it's going to be okay, right? This is the first time that young person's heart has been broken. They don't know that. Big fan of tools. So this is a tool that we created. We have it available through something that's called the Maine Prevention Store. It's free. You can go on here. You can order these, as many as you want. And I really encourage you all, if you're having trouble starting the conversation, you can pull this out with a family and a young person and say, hey, like, this is this little thing I bring up with everyone. it has all these nice options on here. Can we go over this together and maybe think about what you guys feel like you could do? And then the thing we did very deliberately was on the back, there's a place for them to write it down. Because again, best laid plans in the moment, you get home, all of those plans go out the window. So it's really helpful to know what you sort of talked about. So I think that's the end of me.
I'm Jess LeBlanc from Sweetser, and I'm the Senior Director for Crisis. Important numbers to have is our main crisis line, which is the 188 number, and then 988. Both of those numbers are going to get you to the main crisis line. The main crisis line is answered by the organization, by TOA, the Opportunity Alliance. And so when somebody calls that number, there's one of three things that might happen. And one of those things is that the person on the line gets what they need from the phone call, right? And then the phone call ends, and that person may be with their family, or they may be going to a provider meeting or something like that. If that phone call ends, the local mobile team does not know that that happened, right? I don't know that this human is in our area and might need some crisis services later on. The second thing that might happen from that phone call is that the main crisis line might feel like somebody needs a mobile response. And so what happens from there is that they, for our areas, which we're in 8.5 counties, which includes this county here, they do a warm handoff to our triage team. And so what a warm handoff means is that the person's live on the phone and they come to us live on the phone. And then we take it from there, and we get some more information, make sure that there's a safe place for us to go and to meet with them. And then we schedule an assessment. The third thing that might happen from calling this number is a 911 response. If somebody is in imminent risk, if somebody is has a weapon, if somebody is unsafe, they're going to do a 911 response, where sometimes we'll co-respond and law enforcement will secure the scene, and then we'll go in and do our assessment. Sometimes that might mean that law enforcement get there, is very unsafe, and they're looking for an emergency department where they'll have their assessment there. So those are the three things. If somebody goes to the emergency department through police, I'm not going to know about it. I might get something stating that this person is in need in the community, but typically I don't get any type of follow-up or information from about that event happening. So I'm here to talk really about mobile crisis, right? What to expect if somebody in the community calls the number and they need a response. So what we do, again, we make sure that it's safe. We make sure that they don't have access to lethal means. If they do, we work with them in whatever environment they're in. So if they, let's say that they're at home and their mother's next door, we're going to have mom come next door, right? We're going to have some eyes on them until we can get there. Mobile responses are not the same time frame as law enforcement. We're not structured that way. We are a program where we really strive to get there as quickly as possible. And if we can't get there, if we can't get there right away, then we're making plans and we're following up with those plans. So, if we have a plan that somebody is going to check in with us every 10 minutes until somebody gets there, if they don't call in 10 minutes, then we've already come up with a plan for what happens if they don't call, what happens if they don't answer. And then we're gonna follow that plan that they have agreed to. So once we're there with a client, again, we can go anywhere. We can be in provider offices, we can be in a Hannaford parking lot, We have been under bridges, in people's homes, in schools. We really do try to go anywhere because that's least restrictive, right? We want to go to them instead of them coming to us. We do have the availability to have people walk into our office as well. Or we can meet somebody at our office too. So part of what we do is we assess. Our very first thing that we do is we assess risk. We use the Columbia Suicide. We actually do a SAFE-T, which is the Columbia Suicide Enhanced, where we're asking about suicidality, when we're asking about any access to harmful materials, lethal materials. One of the important things when you are talking with somebody who you feel is at risk, using the language of, are you feeling like you're gonna kill yourself? You wanna be direct, you wanna be kind, you wanna be supportive, but you don't wanna tiptoe. You want them to be able to tell you what's going on. You don't want to lead them like, oh, you're okay, right? Like, I hear this, but you know, you're not really thinking about killing yourself. You do wanna be straightforward and supportive. So they're not in fear of telling you things or thinking that they're gonna get in trouble. One of the first things that we see is that people think that they're gonna be institutionalized, they're gonna be hospitalized, they're gonna be taken away from their home, they're not gonna be able to go to school, they're not gonna be able to do their sports. And we don't want them to feel that way. They're already feeling isolated and alone. So we do want to, and I think Dr. Mayhew, you said it beautifully, normalize, you know, their life for them. When we do an assessment, we go through all of the steps of the biopsychosocial. We're looking at them as within all of their, you know, with all of their medical, with their school, with their family, their friends, relationships, all of those pieces. We want to know all of those factors that are going into this and trying to figure out, you know, where is this crisis coming from, and what kind of interventions we can do to either help, you know, resolve it during this assessment, or if it needs to go to a higher level of care. We also want to partner with you. We want to partner with providers during assessments, family members, loved ones. The more information, the better for us to be able to determine what the level of care should be for this individual. There's 3 different levels of care. They can remain in the home and community with either providers, or we can make referrals for providers. I know that it's hard to find providers right now, but that's one thing that can happen during this assessment. We might recommend a crisis unit, which is a crisis residential unit, which is just a short-term 3 to 5 day stay. There's 24/7 staffing and a clinician that's going to be working with the child and their family on the acute issue and making plans for what's next for them. And then there's an inpatient hospitalization, which is the most restrictive, which is scary for kids, which is scary for families, and typically is the last resort, and it's about safety and about acute psychiatric needs. The process to get into the hospital can be a little challenging. We have been fortunate the last couple of months. We have been able to get youths in inpatient settings from the community, but it is challenging. It can take weeks. There is a big need for beds, and not being in an emergency department can kind of, prolong them being in the community, which sometimes can turn unsafe. If somebody is needing a level of care that they can't get access to, things can go, things can go downhill quite quickly. So we would create a safety plan. And again, I can't stress enough that here's a safety plan, here's what we're gonna do, this is the idea. If that idea doesn't happen, knowing what's next is also something so important when you're doing a safety plan. So they know they're not going to be surprised, if mom shows up, at school because they skip fourth period, right? They're not going to be surprised, sometimes if we call for a well-being check with law enforcement. We've talked to them about that. They're in agreement to it. And really the whole goal is to make sure that everybody is safe. So once we do a level of the care from our assessment, part of what we do is our follow-up plan as well. So no matter if somebody goes to, stays at home, if they go to a CSU or they go to a hospital, we're gonna follow up with them. Our hope is to be able to do that for 60 days. Follow-up can be in person, it can be by phone calls, it can be by team meetings, it can be by a whole, it can array with what is needed from that individual and what they're willing to do, right? So some of this is, what's their desire, what are their goals with our interventions. So we make those plans. My hope and my goal is that after each assessment that providers are being called and being talked to about that this is an assessment, this is the outcome. Do you have any questions, concerns? We don't have to just do one assessment. If we get more information and things aren't going well, we're open for 60 days as long as everybody's willing for us to do that. So we can get pulled in, we can do an assessment at any time. We can reassess, we can look at a higher level of care. Sometimes we reduce that level of care when we partner with providers being like, hey, I would really like to make this medication change for this, for this kiddo. Can you check in on them and maybe we can prevent them from going to a higher level of care, because we do know that higher levels of care have risk associated with them as well. Again, after 60 days, if we need to continue to do work, maybe we haven't been able to get a therapist or providers in place, we can keep it open for longer if we need to do that. Some important things to know during a crisis, I can get all the information that I need. I don't need a release. If somebody is at imminent risk, if you feel like they are going to harm themselves or somebody else, HIPAA does go out the door at that point. We have to make sure that somebody's safe in our community. So, if you ever have a question about that or anything like that, you can always just call me and say, hey, Jess, I have this case. I'm concerned about it. I don't have a release. Let's talk about it. You can de-identify it, and we can do some consult there to see what is the next best thing. So I am so sorry I don't have my PowerPoint, but I think I kind of went through everything. Thank you guys.